Hello there. My name is Jordan Jean-Louis. I'm a professor of population health and psychiatry at NYU Grossman School of Medicine. Today, I'd like to spend some time talking about some of the work I've been doing over the last 15 years to engage community health champions as a way to reduce sleep health disparities in vulnerable community, all the while thinking about ways to reduce cardiovascular disease, which is of course rampant in minority communities. In a speech that Martin Luther King delivered to the Second National Convention of the Medical Committee for Human Rights, he ordered this statement: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. This statement has in many ways fueled the work that I've been doing to have direct engagement in communities where there are significant health disparities, especially sleep health disparities, that may place African American or Blacks, if you will, at greater risk for brain injury as well as cardiovascular disease. Kevin Schulman asked this question in 1999, should they be treated the same way? Obviously the answer is yes, but are they? The evidence shows that there are significant disparities at all levels. Here, we're focusing on sleep health disparities. I am quite excited by the fact that over the last 4 decades, there has been a significant interest in sleep research that pertains to minority communities. So notice 4 decades ago, there was very little effort being made to looking at disparities in sleep and sleep disorders. But over the last 10 years, the interest has significantly increased. And hopefully this is also leading to a significant reduction, if not a complete eradication of sleep health disparities. The National Institute of Health, having been made aware of such disparities, convened a conference in 2011 rather, where they brought together several experts in sleep and sleep disorders, circadian science, as well as health disparities, so we could start thinking about what are some of the impediments to sleep health, adequate sleep health among minorities or Blacks, if you will, and also what are some of the strategies to reduce those disparities to improve overall health. So this is a special issue that's currently available. So if you want to know more about the workshop recommendations, I urge you to go take a look at it. Following the model put together by Kilborn, if you want to engage in sleep health disparities, there are actually 3 steps you got to follow. The very first one, of course, is to detect what the disparities might be. So you want to be able to define the health disparities and what communities that you are particularly aiming at conducting research. The second one, once you've been able to detect the disparity, is to really understand what the nature of the disparity is. That is, can you identify some of the determinants of health disparities, as well as some of the mechanisms that perpetuate such disparities? If you are able to understand the nature of that disparity, then you may want to go to the third one, which is where most of my work has been. That is to intervene and translate and disseminate health information to reduce health disparities in minority communities. There are, in essence, 3 sources of disparities in care. The very first one is what we call patient level. The second one we refer to as healthcare system levels. And the third one is referred to as provider level. Most of the work done so far has been at the level of the patients themselves. There's a little bit of effort now by our team to look at what's happening in terms of healthcare disparities, level disparities in the healthcare system itself, and also some of the disparities that have to do with the providers or the PCPs. So the work I'm going to be talking about in a few minutes really centers mostly about patient level disparities that we have been trying to eradicate. This is a conceptual framework for developing a model to address sleep health disparities in minority communities. So essentially, I'm not going to go over that in detail, but notice that it gives you a very nice understanding of how you should proceed. There are 3 unique steps. The very first one is to build a foundation for the work. The second one is to understand how you should engage the community. And the third one is to design very specific activities to ensure that you achieve your goals. So this is a framework that I refer to all the time. And if you want to build your own research portfolio that targets minority communities is a model you may want to utilize. There are three levels of community engagement. The very first one is referred to as transactional. The second one is called transitional, and the third one is transformational. The work that we have been doing over the last 10, 15 years has relied primarily on transformational community engagement because it ensures that we have sustainability as well as ownership of the process, which entails, before you even begin to think about submitting a grant proposal to the NIH, you want to make sure that the community health champions, all the stakeholders are indeed at the table, helping you to think through what's the ultimate way to pose the question in a way that makes sense, and what strategies can we employ to ensure success. Therefore, I would not recommend transactional, which is the old way of thinking about bringing some people in only to advise. It's transitional, also has some level of engagement, but nothing compared to the transformational leadership or the transformational community engagement level, which really ensures success in terms of sustainability of the intervention. All of that, if you were to do it the right way, you would help to build trust. As we know, trust is a significant factor that, in fact, limits the access to care among minority communities. So if you do things the right way at the right level of community engagement with the health champions, it's certain you're going to be able to increase trust. And if you increase trust, you are likely to achieve your goals. There are two very specific activities we have engaged over the last 10, 15 years or so. So the very first one is what we call a process whereby we engage the community to get a better sense what it is that is of concern to them, at least in terms of healthcare. So we utilize something we call a Delphi process, after which, after sessions we have had to talk about different types of health burdens, to get a sense which one they would feel is most important. In this particular instance, sleep disorders in particular were found to be very of concern to minority communities, and be relying on this, we develop what we call the sleep research agenda to eliminate disparities in minority communities, as well as the sleep disparities work group. The second one is a sleep health disparity summit, which we conducted about 2 years thereafter. The point of that was to have a much better sense, what models do we have now we can utilize to reduce disparities in terms of sleep disorders, in this case particularly poor sleep and sleep apnea. So the outcome of that summit was that we put together what we call the NYU Community Activated Partnership. So then the sleep apnea itself is the condition that we've been targeting primarily because of all of the negative consequences that you all know of. By doing community engagement in the community, we go to the barbershop, the beauty salons, the churches, the mosque, somewhere in the Bronx. But all of that has to do direct engagement. So instead of having patient or volunteers or participants come to us at NYU, we go to them. We go to the community where they are most likely to be congregated. And by using this particular approach, we are able to recruit minority patient or participants in terms of clinical trials that we have conducted. We have done a number of trials. Some of them have been completed, others are still ongoing. So today we're talking about the first three. That's pretty much the attitude in terms of what happens in minority communities. It's really not a priority for them, and for a number of reasons, and we'll talk about that later. What we have found in terms of OSA or sleep apnea in minority communities, so we know that for the NSF data, the level of risk is about 28%. If you're thinking about people that are at the barbershop, the beauty salon, and the churches, the level of risk is about 43%. And when you think about people that go to community health centers with different types of sleep disorders, as well as cardiovascular disease, the level of OSA risk is about 59%. Here we show data that indicate that snoring is a significant concern for minority communities. Short sleep, of course, you probably know about this. And please note in the bottom picture where we have the level of OSA risk, which is about 43%. And if you look at people that have been studied at home with a watchpad, of all the people we have assessed thus far, about 87% of them were at risk for OSA as determined by AHI. Here we have some data that shows the level of engagement in terms of referrals to a sleep center for a sleep evaluation. So notice here, if you were to refer patients to a sleep center, so it's only about 38% of them that in fact go get a sleep test done. And what's of interest is that of all the people that in fact went for a sleep test, 91% receive a diagnosis. This in essence tells me that there are a lot of patients that have OSA that have not been detected, therefore they haven't been treated. Here's the first study I'll talk about here, which we call MEDSO. MEDSO was an intervention in minority communities to try to understand what's happening in terms of sleep apnea, develop and deliver an intervention that will make it easier for them to attend a sleep clinic, as well as adhere to PAP treatment. So this shows in a nutshell that if you were to expose Black patients to a tailored intervention that addresses the linguistic concerns as well as cultural concerns, you were almost 5 times as likely to have them go for a sleep test versus somebody who receives standard of care. So what we have learned from that intervention is that Blacks would prefer to have sleep tests being done at home. They would also prefer to have health education delivered by their peers. And also they have indicated significant interest in having a website that would provide information in a way that is palatable to their concern and their needs. And that's what we have done. We'll talk about that next. So PZ is an offshoot of the MEDSO study. The difference here is that MEDSO has had one navigator at the office providing health education. But in terms of PZ, we actually train health educators to deliver CPAP information to their peers. That study is ongoing, therefore we do not have yet the results of that study, but so far preliminary analysis have shown that the intervention is quite successful. So here's what we had to do in essence, because there are very few people who understand, we know about sleep disorders, so we had to train the health educators themselves to help them understand the necessity of sleep health, what sleep health is, and why people should be treated if in fact they have sleep disorders, or in this case, sleep apnea. All of the volunteers we have trained to become health educators, in fact, were certified after a 3-week-long program. The other intervention is what we call TASH. TASH essentially is a website that we have developed to provide health information to Black folks in a way that makes it much easier to understand and to become actionable. So the website is currently available for Blacks at the community level to consult with and have a better sense in terms of what sleep apnea is, the mechanism there whereby we could actually diagnose and treat this particular sleep disorder. In a nutshell, this is what TASH is. We had involvement of the Community-Based Advisory Board, as well as healthcare providers, and of course, all of that was done in direct consultation with the community steering committee. This is what the website looks like. It provides, again, information about how to take care of sleep problems in the event they become a significant issue in their existence. So we have a number of vignettes that describe the journey of a minority patient with sleep disordered breathing. That is decision-making processes, how to get a consultation, how to get a sleep test done, and if positive, how do you get a CPAP machine done, and how do you ensure that they adhere to treatment. So this particular trial was very successful. Recently was published at the JCSM. So it shows the level of self-efficacy increase in all of the 3 domains. That is, risk perception was significantly higher, outcome expectancy was significantly higher, as well as treatment efficacy. We are now conducting a part B of that study, which is to determine for those people who had high level of efficacy, did they in fact go to a sleep clinic for an evaluation and treatment. So this work is done by the NYU Sleep Security Research Team, without which this would be impossible. I thank them for the contribution, and I thank you for listening.